Good evening, Facebook users, and welcome to our TIF Talk Summer Series. My name is Karen Girth, and I'm a Market Development Manager here at Endogastric Solutions. Tonight, we have the pleasure of having Dr. David Forcione here to discuss TIF, GERD, and answer all of your questions. In addition, we have one of Dr. Forcione's TIF patients, Sandra Maynard. She is here to share her story and answer any questions from the viewing audience. Also have my colleague Wendy Profit. Wendy will be monitoring the questions tonight, so viewers, please post your questions for Dr. Forcione. Thank you so much, Dr. Forcione, Sandra, for being here tonight.
Thank you very much for having us. I think this is an outstanding platform, an outstanding resource for patients who are suffering with these reflux symptoms, and hopefully we can answer any and all of your questions today.
Fabulous. So I want to introduce Dr. Forcione. He is a board-certified gastroenterologist who specializes in advanced interventional endoscopy. His expertise is in all aspects of endoscopy, including evaluating and treating disorders. Regional Hospital and a member of the Center of Advanced Therapeutic Endoscopy at Baptist Health, South Florida. He's also an associate professor of medicine at Schmidt College of Medicine at Florida Atlantic University. Very impressive. Thank you for being here tonight.
Thank you so much.
All right, so let's kick off our program. We're going to start off tonight again with a new short segment or icebreaker that we're going to call Fill in the Blank. Perfect. So how it works is I'm going to prompt you with a question, Sandra and Dr. Forcione, or a statement, and you're going to fill in the blank and let us know why you chose that word. So the first two questions are for Dr. Forcione. Here's your question. Dr. Forcione, GERD is blank.
So GERD is many things to different people. You know, from my perspective as a physician, when I'm talking to patients about GERD, I really try to stay away from restricting my definition of it, because it really has a variety of different manifestations. You know, the typical GERD symptoms are going to be heartburn, indigestion, but you can also have patients who predominantly will have a cough or a sore throat or a raspy voice, and it's really all of those potential symptoms manifest in different patients depending upon the circumstances. So it's important to remember that GERD is just not heartburn. It has a variety of manifestations, so it's important to think about that when you're inquiring about treatment options.
Well, your next question, leaving, and you might have already answered this a little bit, leaving GERD untreated is blank.
I think it's largely a really uncomfortable, potentially miserable way to live, particularly nowadays where we have technology and advancements in endoscopy and surgery to fix the underlying problem. Not only is it a bothersome constellation of symptoms for most people, and for many patients, it really affects the everyday quality of life. It affects, you know, many of the things that people enjoy in their day-to-day living, you know, food and dining, to mention a few. But there are very serious medical consequences of reflux, untreated reflux, which can include narrowing of the esophagus and even potentially the development of esophageal cancer if left untreated for many years. So there's quite a range of potential consequences, but I truly think the most significant one is just the effects on your quality of life, day after day, having to deal with it, having to take medications, having to remember to take your antacid pills when you go out to dinner, and restricting what you can eat. So I think it's predominantly a real significant quality of life issue.
Well, thank you for sharing that. And now,
downward. It's really, really miserable. It can be a life of misery. It can make you not want to eat, not want to go to bed, because you're just going to have a miserable, miserable night, and not want to wake up in the morning and start it all over again.
yes, I can only imagine. And we're looking forward to just kind of hearing your journey and your story from, living with GERD to your post-TIF procedure and how you are feeling now. But so let's go ahead and get started. And Dr. Forcione, I want to get started with a few questions. Can you kind of educate our viewers on the difference between occasional acid reflux and chronic GERD?
So, like many things in medicine, the condition of gastroesophageal reflux or GERD is a spectrum. So there are many, many, many patients who have, very intermittent symptoms, and I would bet that most of us on the panel have intermittent reflux if you overeat or eat the wrong thing. The very occasional reflux. But for patients that are suffering on a regular basis, meaning having more than twice a week symptoms requiring typically over-the-counter antacids or regular medications, that's what we would consider in the chronic reflux category. But as I said earlier, it's a constellation of symptoms, and it may not just be the heartburn. You may have more of the respiratory symptoms, the cough, the sore throat, the abnormal or unusual taste in your mouth, the coughing at night, the raspy voice, the regurgitation. When you bend over, you feel food is coming up on you, liquids are come up on you. So, patients may not recognize those as heartburn or GERD symptoms, but those are all manifestations of the same problem. And what we now know is that it really is a mechanical problem. It's not an issue of, well, my body makes too much acid or my body doesn't digest properly. It's a mechanical problem of the anatomy. And you can take all the medicines in the world and it doesn't fix the underlying problem. It's just a Band-Aid effect. And I'm not saying that medications are not part of the treatment options, particularly for the very intermittent, patients with very intermittent symptoms. But we have to remember that GERD is much more than acid. It's a variety of injurious chemicals that our body makes, bile, acid, digestive enzymes. Even just the food we eat is an irritant to the esophagus. And at its very basic premise, this is a mechanical problem with the way the esophagus and the stomach interact. It's a very complex mechanism. And we know in patients who have significant chronic GERD symptoms, it's almost always a mechanical anatomic problem, and we now have the power to reverse that and restore it to its native anatomy, what it's supposed to be.
Thank you for that explanation. And you kind of just mentioned it is a mechanical issue. Can you kind of go into fixing that mechanical issue and a little bit more about the TIF procedure? That was a good segue.
Sure. So, if you think about how we digest and, how we swallow food and liquids, obviously the esophagus is the conduit. When you swallow food or liquid, it goes down that tube called the esophagus. and it has to get through that tube to get into the stomach. Under ideal circumstances, what goes into the stomach stays in the stomach, and that includes what you eat, what you drink, and what your body makes. Your body makes the acid, your body makes bile, your body makes digestive enzymes to break down those products. But the goal is for all of that to stay in your stomach and not to flow backwards up in your esophagus. Our body, like with many parts of our body, is extremely intelligent, and it was made to deal with all of these stressors that it faces over the course of a day, and it's evolved to have a valve mechanism. And what that means is after you eat and drink, those contents are supposed to be secured in your stomach by a valve mechanism, which means that you have tone or muscle contractions at the bottom of your esophagus. You have the diaphragm working with that muscle, basically all to prevent those contents from coming up in your esophagus. Your esophagus does not like to have those things coming back up on it, and that's why it will hurt, that's why it will feel abnormal, and potentially those contents can come up and irritate your airway and your vocal cords, and cause those types of symptoms. So our body is designed to have a one-way valve. It goes in, but it doesn't come back up. The whole purpose of the TIF procedure is to take those patients who have abnormal valve mechanism, meaning they have a weakness of that valve, so that even though it can go into the stomach, there's just a higher frequency and propensity for it coming back up. And there's a lot of reasons why that valve fails. But at the end of the day, correcting the valve is an excellent way of restoring the normal valve function and preventing reflux type symptoms from happening. So at its basis, the TIF procedure is basically an endoscopic way. It's all done incisionless. There's no skin incisions involved with the fundoplication part. It's a way to restore that valve function. We tighten the valve between the stomach and the esophagus, and that prevents the reflux of all of those injurious chemicals and food substances.
Oh, thank you so much for that information. We have got tons of questions, and people want to hear your answers. So we're going to go to Wendy, who has some questions from our viewers.
Yes, thanks everybody for sending these in. Dr. Forcione, I have Regina asking if insurance can cover this type of surgery.
That's a great question. So most insurers do now cover the TIF procedure. It's a little bit variable depending upon where you live and what your insurance coverage is. But increasingly, there has been uniform adoption by insurance companies to cover the procedure. I can give you an example that Medicare, which is what most individuals will carry after the age of 65, fully covers the procedure. And what I have found is very little resistance to insurance coverage. Occasionally, we have to go through some approval processes, but it's not an obstacle to pursuing the procedure. And I personally have never had a patient get denied or have to pay out of pocket for it. So, the insurance companies are smart. They're starting to see this as an excellent alternative to chronic medication therapy. If you look at it from an economic perspective, it costs a heck of a lot more for insurance companies to pay for chronic antacid medicines. We're talking over decades, for some patients, as opposed to a one-time procedure. And so looking at it from an economic perspective, which, is unfortunately is what most insurance companies do, they realize that this is the smart choice. And not only is it the smart economic choice, it's the best choice for most patients, is to have a mechanical repair of the valve.
Very good, thank you. Also, we have Madeline writing in asking, I was told by my gastroenterologist yesterday that there is no remedy for silent acid reflux. Any thoughts?
So silent acid reflux has different meanings in different contexts. So most people, when they make reference to silent acid reflux, these are patients that don't have typical heartburn, regurgitation type symptoms. They have more of the respiratory, vocal cord type symptoms, and they'll only complain about a cough or sore throat, raspy voice. They don't feel the common heartburn type symptoms, and so they're often diagnosed, oftentimes by ear, nose, and throat doctors, as having silent reflux because they don't have the typical symptoms. But that is a real, symptom complex that patients suffer from. It can be as debilitating as the run-of-the-mill reflux, heartburn type symptoms, and it can have very serious consequences for recurrent pneumonia, bronchitis, type symptoms. We've had patients who, make their living out of, acting and singing, and when they don't have a voice, there goes their job opportunities, and so that can be a very meaningful symptom for patients. So that's what people refer to as silent reflux. It is sort of technically silent, but it has true physiologic consequences to the patient. So it's a bit of a misnomer. It just means that we can't recognize it by traditional symptoms. It doesn't mean it shouldn't be treated, and it actually should be treated very aggressively, perhaps even more aggressively than your run-of-the-mill reflux symptoms, because the airway complications can be, very, very significant.
Gosh, I didn't even think about the airway complication. That's a great point. I have Carmen asking, does TIF work for non-acidic reflux?
That's a very good question. So, it's just important to remember that reflux does not mean acid reflux. So reflux just means that gastric stomach contents are coming up into the esophagus at a disproportionately high frequency and high volume, and that leads to symptoms. And acid is just one component. The other major components are bile and digestive enzymes. Remember, your stomach makes enzymes to break down food. Acid is not the only component of that digestive process. And this is actually a very important issue. And this is one of the reasons why not everybody responds to antacid medicines, because many of their symptoms could be related to non-acidic components. And unfortunately, we don't actually have any medications that reliably have neutralizing effects on bile or digestive enzymes. So the only medication class we have are antacids. And you have to remember, that's only a fraction of what people reflux. There's all sorts of things that people reflux. This is a common reason why people have refractory symptoms, or they still have symptoms despite adequate antacid medications, or they have breakthrough. They're taking their omeprazole, but they still have to take Tums on top of that, or Gaviscon. This is exactly the reason, because it's not just acid.
That's so interesting. Thank you. We have sorry, I have to jump back up here because I went too far down on my screen. We have Matt asking, how long does it take a patient to find relief without PPIs after a TIF?
So it's quite variable, I would say. So in my own practice, and there's a lot of variability as to when clinicians will discontinue, the patient's usual antacid regimen. In my own practice, I continue patients on all of their same medications for the first 3 months after the procedure. And one of the reasons is that as part of the protocol for patients undergoing the procedure, we do want them to be on a specific diet regimen. And I'm so glad that Sandra is here today. She's really the star of the show. She's the one that has gone through the procedure. She's had a successful recovery, and I hope the audience really takes advantage of her wealth of knowledge as not only a patient, but a very somebody who has very intensely researched the procedure and really understands it. I think actually more than many of the gastroenterologists that are probably seeing patients with this. So I hope the audience takes advantage of her wealth of knowledge. But just getting back to the question, my own practice is to continue it for 3 months after the procedure. We recommend a diet regimen for about 6 weeks to 7 weeks after the procedure, and the goal of that is to allow the healing process to take effect in its most optimal way, for the sutures that we place, the plications to take effect, and that's why I continue the medicines. I want the healing to happen in an optimal environment as possible, and then everybody so far at 3 months, I begin the taper, and I usually, cut it down in half at 3 months, and then 4 to 6 weeks later, we cut it down again. And so I tell patients, by the end of the year, and this is based on, official research data that's been published, and there are many publications on the procedure now, having going back now, I think, 13 years, the procedure's been FDA approved. That over 80% of patients will be off all medications by a year, and that's been my experience as well.
Well, thank you, Dr. Forcione. That is such a great transition. I would love now for Sandra. Sandra, thank you again for joining.
Thank you.
We would love, as you said, you are one of his patients that has had, extremely great success, and we'd love to hear kind of your journey, if you don't mind sharing with all of our viewers, because I'm sure they'll have a lot of questions.
Thank you. When I was I'm 77 years old. When I was a young woman, I was 19 when I had my first baby. I was finished with my 3 children by 23. I had probably would call it heartburn during my pregnancy. I never had it again till many, many years later, until the 90s. My father, however, died in 1983 of esophageal cancer, and it scared me. And at first, I believe he had Barrett's disease, and it progressed. If I'm not mistaken, I was pretty naive about it, but he died a pretty rapid, miserable death with esophageal cancer. So the first times I started having heartburn, I looked for a gastroenterologist here in my town of Lake Worth, and I found a champion in that doctor, and he knew I was worried, and he said, we're going to check you, and he said, I promise you this, you're not going to die of esophageal cancer. I'm going to keep an eye on you. Well, you talked about the economic impact of GERD, and I'll tell you, undergoing endless endoscopies and every other test are expensive tests. Plus, they're hard on your body. It's no fun to keep going under anesthesia to have those things. And he saw that I had some issues, and he did so many tests on me. He did the Bravo study. I had monography. I had, am I saying that right, Dr. Forcione?
Manometry.
Yeah, where they checked my swallowing. I did have low manometry scores. And we just could not get this taken care of. I was on PPIs for about 17 years, and he kept telling me, you do not want to stay on these. And he would try to wean me off them. And I was too miserable. I was eating every purse I had Tums, Gaviscon, Rolaids. And sometimes we'd have to pull over on the side of the road for a 7-Eleven to find Rolaids or something to give me just temporary relief. I was so miserable with GERD symptoms. And finally he said, there is a surgery for this, Sandra, that I think will suit you. Well, I started looking into different esophageal cures, and not cures, but treatments for this surgery-wise. They scared the heck out of me. And then he said, there's one that I think you should investigate. It's called TIF. I said, all right. He said, I was 75 at the time. He said, I'll tell you what, I might have a problem finding a surgeon who wants to do surgery on you at your age. You're very healthy. I was a bike rider. I'm active. I'm cheerful, but I was old. And one day he called, he said, I found somebody in Boca Raton, Dr. Forcione. He said, I think he's going to be the perfect match for you. And I went, and it was at a time, Dr. Forcione, it took a really long time from my first appointment to getting the surgery. I think there was some issues with the mechanical things going on. By the time he gave me a date for this surgery, you'd think I was going to the prom. I was so excited and so happy. And he did the surgery in January, and I'll tell you, I did follow his recommendations and stay on the PPIs. He gently weaned me off them, but I never, ever have had heartburn, GERD, or any kind of regurgitation since. Before that, when I was suffering so, it was especially bad at night. I suppose after I ate, I knew to eat early. We changed our dinner times. I was eating dinner at 4:30, no fun, so that I could have a lot of time to digest my food before I went to bed. And I would get in bed and it would just start coming up. And I'll tell you, it was like, probably would feel much the same as if you drank Drano. It was so miserable, so acidic. I just felt like I was raw. Well, Dr. Forcione put me through some tests and discovered that I had, he said, a very large hiatal hernia. I believe you said it was between 6 and 7 centimeters that I needed to have repaired, along with the TIF. And I just decided to throw all my confidence to Dr. Forcione and let him guide me. And I went in saying, we're going to get this fixed. I'm going to have my life back. At our house, we are great cooks. My husband was in the Air Force. We've lived in a lot of places. I lived in Japan, Italy, Hawaii, Germany, and many places in the States. So we are used to a really big diet. We learned how to prepare those foods. No fun at all when you can't eat them. Be honest with you, I enjoy a beer. I enjoy a cocktail. Love chocolate. Off the charts for me. No tomato-based anything. Spaghetti could send me into 24-hour spasms. It's one of my favorites. So I had the surgery. Ta-da! It was a miracle. It really was. I had been on an antidepressant before I saw Dr. Forcione. I spoke with my doctor, and he agreed that I could, if I was feeling better, my health was better, I could try weaning myself off those. And so I did. I haven't had one since. A lot of things changed in my life for the good. The diet after the surgery, I thought I had a bad diet, no fun diet before. The diet after the surgery was not fun at all. My husband's a great cook, and he was really, really creative and tried so hard to find things that appealed to me. When I went into surgery, I think I weighed about 134 pounds. I'm 118-ish now. I haven't gained any of the weight back. I eat really healthy. I regularly ride my bicycle 20 miles at a time. I walk my dog twice a day, a mile each time. So it gave me back my life. And at 75, I was pretty much saying, I don't want to keep doing this.
Sandra, that's so wonderful to hear. And I know there's so many people out there listening, tonight that do, feel the same way. And I hope that, your story as, let them know and encourage them that there are other options. I know you mentioned, Sandra, that you did have a hiatal hernia, and Dr. Forcione fixed that. Dr. Forcione, could you just touch on a minute on hiatal hernia repair with the TIF procedure, and if the recovery is different versus a straight TIF?
Great question. So hiatal hernias are very common. Just so people understand what a hiatal hernia is, that is when a portion of the stomach is actually pulled up into the chest cavity. Normally, the entire stomach is supposed to sit in the abdomen, sort of below the chest, but what we call below the diaphragms. When people have hiatal hernias, that means part of the stomach has been pulled up into the chest, and that is a common finding, but it's also a risk factor for having more significant reflux. Doesn't mean that everybody with reflux has a hiatal hernia, but there's a clear correlation between the two. So it's well known that in order to optimize the anti-reflux barrier, the valve mechanism, as we call it, having a normal anatomic alignment of the stomach is optimal. So I would say about 2/3 of patients will have the need for a hiatal hernia repair as part of the TIF procedure. It's done as a simultaneous operation, so we fix the hernia first and then do the fundoplication or the valve repair as a secondary procedure. I would say, certainly in my practice, I think in most practices, without exception, that's done as a minimally invasive procedure. It's either laparoscopic or robotic in the technique. And it takes usually between 45 minutes to an hour and a half to do the hernia repair, and another 30 to 45 minutes to do the valve repair. So the entire duration is about an hour and a half to 2 hours to do everything for most patients. In most settings, it actually doesn't change the recovery for most patients. I do believe, Sandra, you stayed a couple of days in the hospital after your procedure.
I had a couple of strange things happen. I got a little, for some reason, I showed up with a little kidney infection when I was in there, and I think I had a little respiratory infection.
Yeah,
but I'm old.
Some asthma. Yeah. So most patients, so certainly if there's a TIF only, no hernia repair, all of those patients go home right after the procedure. If patients have both the hernia repair and the TIF procedure, I would say still the majority of those patients go home. I sort of leave it up to the patient. We kind of assess how they feel after the procedure. Most patients, if it's a stay, it's an overnight stay, and very few patients will need more than Tylenol after the procedure as part of the recovery. So
I was not in pain.
Yeah, pain is not a common.
Minimal pain.
Yeah.
Actually, and I have no incisions.
Yes. So that's clearly a benefit of the procedure. I do think it is important, for those of us who do these procedures, we really carefully evaluate patients for hernias, because that's a potential reason why a anti-reflux procedure or TIF procedure alone may not be completely effective. So if we do identify a hernia, we generally do recommend fixing that as well, because restoring the normal anatomy is really critical for the valve repair to work. It's all a symbiotic, everything works together when the stomach is in its normal alignment.
Can I say also, when I had that stomach in my chest cavity, I don't know if there's any correlation. As I said, I don't have any medical background. It seemed like I had a lot of pressure in my upper abdomen. I felt a lot of pressure, and I felt a little breathless often.
Mm-hmm.
I haven't had that.
Yeah, that is a common symptom in patients who have a large hiatal hernia. Is it actually can compress the lungs and can affect respiratory function, not to mention the the regurgitation and the reflux type symptoms. So in general, the larger the hernia, the more symptomatic patients are. And really with very few exceptions, there isn't an anatomy that precludes the TIF procedure. So kind of no matter how big the hernia is, it can still be done. Just as I said, we fix the hernia first and then do the fundoplication, and it all works together quite beautifully to restore the normal valve function.
I also would like to add, I was not really quick to return to my normal routine. I understood what was going on inside with these procedures and that there was a great deal of swelling. I rested a lot. I fell in love with Netflix, my iPad, my elevated bed. I had the beautiful opportunity to really rest, to eat very, very carefully. I ate minuscule amount many times a day. I found that certain things affected my whole system, gave me dumping syndrome. That was mostly from sugar. My weakness was sugar. So I learned to even restrict fruit juices. My stomach got back to normal. I'm in great shape.
Just to kind of catch on what you were saying about the weight, and I think this is the experience of most practitioners who do this. Most of our patients actually do lose weight after the procedure, and I've seen, I would say on average it's about 10 to 15 pounds. I've seen a couple of patients have more than that. It's not meant to be a weight loss surgery by any means, but because of the dietary modifications that are highly, highly recommended after the procedure for the first 6 weeks. And I also think because we're restoring the anatomy to a normal alignment, people feel full faster. I can't really say that that's a permanent fix, but for a lot of patients, it jumpstarts their journey on their weight loss. And people, that's one of the things they tell me when I see them in follow-up is, am I supposed to have lost this weight? And I do advise them and guide them before the procedure that they will lose weight. And unfortunately for many of us, that's a good thing.
When I saw you for my pre-op, I told you I was thinking of the keto diet, and you said, hold off on the diet.
Yeah.
And I'm glad I did, because I didn't want to get underweight.
Yeah.
And as I say, I could not eat much. I still don't eat much. I eat much smaller portions. My husband often will have a lovely grilled hamburger. I've convinced him now, instead of a hamburger for me, I'll have slider. And he makes me a little tiny hamburger. And that's all I need. That's all I want. And
no, it's interesting that you say that, because I do think going through the whole process from pre-op to the procedure to the post-op, people think about their whole sort of process of eating and drinking, and they sort of relearn what the right technique is. And most patients, after undergoing this, are so satisfied with their outcomes, they don't want to go down that pathway again of doing things that they know will promote reflux, which is generally overeating, eating the wrong foods. And it's kind of a sort of a re-education of the process of eating and digestion, and people are able to maintain that because they feel so good and they don't want to revert back to their old ways.
Absolutely.
That's interesting. I actually just had a question, if I can jump in for a second. A couple of questions that I think fall into this track is, number one is the goal really after TIF to return to a normal diet? And what I'm hearing you say is you need to really relearn what is going to be right for you. And I would guess that differs by individual. But Also, if you have any thoughts on that, Dr. Forcione, please share. And then after Sandra, we have a question about what foods worked really well for you regarding the diet post-operatively. What were the things that you saw helped you feel, like just fulfilled, but also at the same time didn't make you feel bad?
That's an excellent question, and one that we get very often when we have this initial preoperative discussion about what the procedure can do for you. And I really try to remind patients that this is not a license to, go into an unhealthy way of eating. I really try to transmit to them that this is not, a free pass to eating foods and eating volumes of foods that will promote reflux. No matter how good the anatomy is, how tight the valve is, you can beat it by overeating and eating the wrong food. So we still really try to impart on the patients that this is going to reset your anatomy back to the way it's supposed to be. You're going to be able to enjoy foods much more than you used to be, but this is not a free ticket to eat the foods that we know will cause reflux, even if the anatomy is completely perfect. So it's sometimes hard for patients to sort of acknowledge that because they want to just sort of dive back in. But it's really important to remind them that we still need to be cautious with avoiding and restricting things, foods and liquids that we know no matter how good the anatomy is. And so the ones that I always come to my mind are carbonated beverages, sodas. Anything with carbonation will promote reflux. And happens to me all the time. If I drink a carbonated beverage, I'll have reflux. Chocolate is another one. Alcohol and caffeine can also promote. But certainly I do tell patients, after the procedure, yes, you can have coffee. Yes, you can have, alcohol, but it's not a free pass to, drink in excess or to eat in excess. But your quality of life almost universally will be better with restoration of the anatomy.
That's so interesting.
Thank you.
There were several foods that I decided I could do without. One of them is carbonated beverage. Rarely, I'll drink an almost flat Coke. I'm from Georgia. I grew up drinking Coca-Cola, and as I confessed earlier, I really enjoy beer. I have my beer at lunch, generally early in the day, so I'm not going to bet on that. I do not eat big bites of anything. They've talked about esophageal spasms. I'm not sure I even knew what it was, but I knew that pressure, and I knew that came from eating too fast, eating too large a bite of anything. When I say I chew my food, let me tell you, Gerber's has nothing on me. I pulverize every bite that goes down. I really want to take care of my body now. It feels great. And so things that I ate. First of all, I bought a hand immersion blender. I blended everything for weeks. I like Quaker oatmeal. My husband would make oatmeal and he'd blend the hell out of it. It was probably like drinking oat milk. I really watched sugar. I would have a little Manuka honey in it, and I would have a little sweetener in it. That was one of my favorite things. As I was able to start eating soft foods, soft scrambled eggs were good. I'm a Georgia girl, love my grits. So I often had grits. We made wonderful, mild soups with vegetables, minimal tomato in that, minimal onion, minimal garlic, and pureed it. I a mild bisque of anything is great. I would cut it with a little milk, a little half and half. By the time I got back to healing enough to have a normal diet, I really enjoyed cream soups. Like cream of chicken was one of my favorites. Even Campbell's cream of chicken, I ran it through the blender. Just minimal chunks. And I think that really helped my healing process. As I say, lots and lots of rest, mild exercise, walking. Dr. Forcione told me to try not to be lifting anything for the first several weeks. Not that I was much of a lifter anyway, but I just watched it. And that's a major surgery. I know you don't have an incision, but your body goes through a lot with that surgery. And as I said, the more and more I read about it, the swelling that goes inside after you have a procedure like that, you've got to give yourself time to heal. So I did allow myself time to heal. And if you have the luxury of taking it easy for a few weeks after the surgery, I think you'll be better off. And my long-term results have been great. I had this a year ago, January. I went through COVID, and I've healed nicely.
That's so wonderful
to hear that.
I'm still careful, I'm still careful eating bread and meat because those things are just hard to go down. And I try not to overeat, so I don't even want to drink a lot of liquid when I'm eating, so I moderate that.
Sandra, we love hearing your story, and we're so happy that you are feeling so great now. And we know that, a lot of people are watching you. Stay tuned. Sandra is telling her story on our GERDhelp.com Facebook page. So please continue to follow her and hear about her story. We're going to go ahead and wrap it up. But Dr. Forcione, do you have any last words for our viewers and any tips, for success for living GERD-free?
Yeah, I think my biggest piece of advice is to take it seriously and realize that you don't have to live this way. There are, options. There are alternatives to medications. And it's not a one-size-fits-all. I'm not saying that this is for every single patient out there, but if you're struggling with symptoms or you're concerned about the side effects or you're tired of taking medications all the time, if you've changed the way you're living because of it, I really encourage you to have a discussion with your gastroenterologist. This is now a well-established procedure. We're talking 25,000 plus procedures done, very, very impressive safety profile. And we didn't get into that part of it, but an extremely safe procedure. Again, bringing back to the point of most patients go home right after the procedure. That is a very unusual aspect, for virtually any kind of surgery. So, we're talking about a safe and effective option, but I just encourage you to talk to your physician. They will know about this. If they don't know about this, you can educate them about it, and really seek out somebody in the area that can offer these services. And I think in most parts of the country there are people that are trained in doing this and are experts at doing this. Just don't live in isolation. You don't have to live like this, for the rest of your life, and take action and get your life back.
Wonderful. And then Sandra, do you have any last parting words for our viewers? Anything that?
Find the right doctor. I know I did. You can if you're in the Florida area, I recommend letting Dr. Forcione your hero too.
Wonderful. Yes. If you are in the South Florida, Boca Raton area, Dr. Forcione is there. If you're located outside Florida and like you said, look for a TIF trained physician in your area, you can find them on our physician locator at GERDhelp.com. Again, we thank you both so much for joining us, and you gave a very informative talk tonight, and thank you so much for joining. And Facebook viewers, we will see you next week on our next TIF Talk.
Thank you. Thank you so much.
Yeah.